Sepsis is back in the news. I doubt many coders are just unaware about these definitions, and that may lead to differences between a coder and a DRG auditor. Let's understand this with an example of a practical scenario. Patient presents from nursing home where he was found unresponsive with high fever and tachycardia of 122. After admission, the lab work did show that the patient had WBC of 26,000 and chest x-ray showed pneumonia. At the nursing home, the patient is known to be very alert on most days. IV antibiotics were started and the patient rapidly began to improve. And by day 4, the altered mental status had cleared, lungs sounded much better, and WBC had improved to 10,000. During the workup, the patient was found to have encephalopathy due to sepsis. Patient's mental status was at baseline on day 5, and the patient was discharged back to the nursing home. Final diagnosis for this patient were 1. Sepsis on admission due to pneumonia, 2. Pneumonia, 3. Encephalopathy due to sepsis and pneumonia, and 4. Fever and WBC due to sepsis. Pause a while, and now I request everybody to try assigning the codes for this case. Hope you are done. Before we move on for the rationale and the explanations for this scenario. If we had to code correctly, we need to have some basic idea about the sepsis 2, 3, and 2.5 criteria. Sepsis remains at the most frequently posed query among CDI professionals. Sepsis tops the list among the querying opportunities, followed by respiratory failure and malnutrition. Sepsis is a difficult condition to diagnose, frequently requiring a team of specialists. It requires a lot of resources to treat. Do you guys know about Sepsis 2, Sepsis 3, and Sepsis 2.5? Sounds like software updates, but in reality, this is all that we need to know to become perfect in coding for sepsis. Per ACDIS, Sepsis 2 is defined as a known or suspected infection plus 2 or more SIRS or systemic inflammatory response syndrome criteria. These are usually described as fever or hypothermia, tachycardia, tachypnea, leukocytosis, or leukopenia. Infection plus 2 of these was considered enough to meet the definition of Sepsis 2 and code it, but many thought this was too broad and led to overdiagnosis. That changed in 2016. An international team of experts released a paper on Sepsis 3, which revised the definition to a life-threatening organ dysfunction caused by a dysregulated host response to infection. While some have embraced this new definition, others have argued that Sepsis 3 raises the bar too high and is not well suited for early detection, which is key to staving off long hospital stays, longer recovery, and death. This ongoing debate and clinical murkiness has unsurprisingly led to insurance denials. Payers will use whatever definition is at hand to deny sepsis and downgrade a DRG. If clinicians use the broader Sepsis 2 and payers use the narrower Sepsis 3, there is likely to be a significant number of audited records that would qualify for a clawback. Bedside clinicians may prefer the breadth of Sepsis 2 to ensure no case of sepsis is missed, while payers may opt for the more restrictive Sepsis 3 to maximize the specificity of diagnosis. Hospitals will continue to support their clinicians' diagnoses of sepsis and repeatedly appeal the audit. Payers will back their own clinical criteria and insist on recovery of excess payments. The more aggressive the pattern of denial, the more the perception that the Sepsis 3 definition is used simply as a means to avoid payment. Eventually, lawyers get involved. Nobody wins. This problem is not isolated to the diagnosis of sepsis. Payers may use competing objective criteria to contest clinical diagnoses such as acute kidney injury, malnutrition, and acute respiratory failure. An offer from a private payer to determine a mutually agreeable definition of sepsis presents us with a unique opportunity to bridge the gap between clinicians and payers. Within the Sepsis 2.5 model, organ dysfunction must be documented as attributable to sepsis and not another concurrent or chronic condition. Okay, let's learn the definitions of acute organ dysfunction for Sepsis 2.5. What are the acute organ dysfunction parameters? Acute encephalopathy is the alteration of the patient's baseline level of cerebral function attributable to infection. Arterial hypertension is defined as a systolic blood pressure less than 90 millimeters of mercury or a mean arterial pressure less than 65, or a decrease in systolic blood pressure by more than 40 millimeters of mercury from baseline, or the initiation of a new vasopressor infusion. Acute kidney injury is identified by an increase in serum creatinine by 0.3 milligrams per deciliter or more within 48 hours, or an increase in serum creatinine to 1.5 times baseline or more within the last 7 days, or urine output less than 0.5 milliliters per kilogram per hour for 6 hours per kidney disease improving global outcomes criteria. Hyperglycemia is noted when the serum glucose measurement is greater than or equal to 200 milligrams per deciliter in the absence of a diagnosis of diabetes mellitus, or there is a specific notation of exacerbation of diabetic hyperglycemia related to infection. Acute respiratory failure is indicated by signs and symptoms of respiratory distress and either room air oxyhemoglobin saturation less than 90% or room air PaO2 less than 60 millimeters of mercury, or a PaO2 FiO2 ratio less than 300 if the patient is not on supplemental oxygen, or an acute decrease in PiO2 FiO2 ratio with known underlying pulmonary disease, or a PiO2 decrease of 10 millimeters of mercury over baseline values, or the need for supplemental oxygen therapy greater than 2 liters per minute over baseline, or the use of high-flow nasal cannula, non-invasive positive pressure ventilation, or mechanical ventilation to achieve target oxyhemoglobin saturation greater than 94%. Coagulation abnormalities are defined as an international normalized ratio greater than 1.5 or an activated partial thromboplastin time greater than 60 seconds in the absence of an intrinsic coagulation disorder or the use of exogenous anticoagulants. Thrombocytopenia is identified by a platelet count less than 100,000 cells per microliter and a decline of 50% or more from baseline, with the baseline being greater than or equal to 100,000 cells per microliter. Hyperbilirubinemia is characterized by a total bilirubin level greater than or equal to 2.0 milligrams per deciliter and an increase of 100% from baseline, unrelated to known underlying disease of the liver or biliary system. Hyperlactatemia is the acute elevation of serum lactate greater than or equal to 3.0 millimoles per liter or 27 milligrams per deciliter. Cardiac dysfunction may include non-ischemic acute myocardial injury attributed to the septic state, new-onset atrial fibrillation, or the syndrome of sepsis-induced cardiomyopathy in the absence of an acute ischemic myocardial event as the etiology of cardiac dysfunction. How many of our coders know how to pick up these conditions from sepsis records and query for severe sepsis if not documented? Let's understand how this changes our DRG in the case presented. The patient presents from a nursing home where he was found unresponsive with a high fever and a tachycardia of 122. After admission, the lab work did show that the patient had a white blood cell count of 26,000 and a chest X-ray showed pneumonia. At the nursing home, the patient is known to be very alert on most days. Intravenous antibiotics were started and the patient rapidly began to improve. By day 4, the altered mental status had cleared, lungs sounded much better, and the white blood cell count had improved to 10,000. During the workup, the patient was found to have encephalopathy due to sepsis. The patient's mental status was at baseline on day 5, and the patient was discharged back to the nursing home. The final diagnoses for this patient were 1. Sepsis on admission due to pneumonia, 2. Pneumonia, 3. Encephalopathy due to sepsis and pneumonia, and 4. Fever and elevated white blood cell count due to sepsis. Rationale. We all know that the principal diagnosis is going to be A41.9, that is sepsis. But how many of us know that we should code for severe sepsis as the patient also had septic encephalopathy documented? Many coders live in the limelight that the documentation of any organ failure is what is required to code for severe sepsis. That's not true. The definition says any presence of organ dysfunction is coded as severe sepsis. I hope you kind of understood now why coders make mistakes while capturing the codes for sepsis versus severe sepsis. In this case, A41.9, which is sepsis unspecified organism, would be reported as the principal diagnosis, J18.9, which is pneumonia unspecified organism, G93.41, which is metabolic encephalopathy, and R65.20, which is severe sepsis without septic shock, would be reported as additional secondary diagnosis codes. No codes were assigned for the symptoms of fever and elevated white blood cell count since these were documented as due to sepsis. Since these are common symptoms and clinical indicators in patients with sepsis, no additional code is needed. Severe sepsis was also coded R6520 since the patient did have documented septic encephalopathy. Encephalopathy is listed as one of the organ dysfunctions in the instructional notes within ICD-10-CM at R65. The correct MSDRG for this case is 871, which is coded with MCC, major comorbidity and complication. Learn something new? Look out for more interesting case studies and learn practically.